So a very good evening, one and all. Very good evening to my juniors, my seniors, my peers in medicine. We've gathered here today for an academic feast to follow on a topic that is often not discussed. It is quite common in our medical circles that we discuss chronic diseases from the perspective of diabetes, hypertension, stroke. Nowadays, we're also discussing heart failure. We're discussing pulmonology aspects like asthma and COPD. But an often missed opportunity is discussing the brain from the perspective of dementia. As you all know, dementia is quite common in practice. It's just that it is often detected very late. The Lassie study, which was an Indian study, showed that there are approximately 8.8 million patients with Alzheimer's disease over the age of 60 in India. And paradoxically, this population is more female and more concentrated in the rural areas. To take us more towards caveats of dementia, especially with a focus on Alzheimer's disease, we have today a leading expert in the field. I have the honor of introducing our esteemed speaker for the day, Professor Dr. B.K. Madhusudan sir, who's the lead consultant neurology at Haster Hospitals, Bangalore. Sir is presently working as HOD and senior consultant neurologist in charge of the stroke services in Sagar Hospital. He is also trained in stroke neurosurgery.
Now I am in Aster Hospital.
Aster Hospital.
Aster RV.
Sure, sir.
Yeah.
Also trained in stroke and neurosurgery with TCD medicine. He has a keen interest in neurohabilitation and stroke and other neurological disorders. As sir rightfully said, in the past, he served as head of the department and senior consultant of the respective department. He's also completed his MD medicine and his DM neurology from esteemed institutes. Next. He's professor and he also served as professor and head of the Department of Neurology at Rajeshwari Medical College Hospital from 2015 to 2020, has been an EC member to the IMA, holds excellence in treating patients with epilepsy, pre-surgical evaluation of medically refractory epilepsy, vagus nerve stimulation, stroke, neurosonology, and neurorehabilitation. He's performed many neurosonology procedures till now independently, and also has various publications in national as well as international journals to his credit. Moreover, he's also served as the principal investigator to more than 10 research trials in fields of stroke, epilepsy, migraine, and multiple sclerosis, also being awarded with the Shining Star Award from Deccan Herald in 2020 and the Best Doctor South 2024 by Outlook Magazine for Neurology. With this esteemed record, I hand over to the esteemed speaker for the day. Over to you, sir.
Thank you for introducing myself. So I'll be today speaking about the disease, that Alzheimer's disease. So I think all of you can see the slides.
Dear sir, the camera is not visible. However, if you could on the camera.
Start your video. Yes. Can you?
Yes, sir.
Yes. So today, on occasion of World Alzheimer's Day, usually September 21st, we celebrate as an Alzheimer's Day. On this occasion, I would like to present a little bit about the Alzheimer's disease in detail, and also dementia in brief, because this is one of the very important topic, because nowadays we deal with a lot of acute diseases of diseases in neurology, like stroke, epilepsies, and infections. However, these chronic neurodegenerative disorders are not spoken much in many of the forms. So today I would like to enlighten a little bit about the Alzheimer's disease. Shall I start?
Sure, sir.
Can you see these slides from my side?
We are able to see the slides, sir. You'll have to maximize it, however.
Yes.
Yes.
Now
sir.
is it okay? Visible. Yes.
It's visible.
So today the talk is about the beyond memory, understanding the spectrum of Alzheimer's symptoms. And I'll be briefing about what is the burden of the disease of this in India, and little bit about the pathology, and the symptoms, how to identify the patients with Alzheimer's disease, and what are the reversible and non-reversible dementias, and differential diagnosis, and what are the treatment aspects, and what is the future research concerned with Alzheimer's disease overall. So coming to the prevalence of Alzheimer's disease in India itself, it amounts to about 3.5 million active cases of Alzheimer's disease and other dementias. Overall, dementias all over the world is about 50 millions, and in that, most of the people are in the underdeveloped countries or in the developing countries. The reported prevalence rate in India is about 4.3%, and by 2050, this is projected to become the second largest number of dementia cases in the country. So, what are the differential diagnosis of different types of dementia? You should know how to work it up, right? So, all the dementias are not Alzheimer's disease. However, majority of the dementias which are irreversible are all Alzheimer's disease. That means up to 60 to 70% of the dementias amounts to about Alzheimer's disease. So, how to differentiate about this? The initial stages, the patient may have mild cognitive impairment here, and they can have a subjective cognitive complaints. So patient complain little bit of memory issues, or sometimes the attenders of they can also inform about mild forgettingness in the patient. And there are various objective cognitive measures which we can measure the cognitive assessment can be done, and intact activities will be there in these patients, and they can do their activities of daily life. Some of the reversible causes also you should know in these cases, like patients with depression, any drug side effects, some of the metabolic disorders, vitamin deficiencies like B12 deficiencies, infectious disorders, neoplasm, normal pressure hydrocephalus, subdural hematomas, and metabolic causes are some of the reversible causes which can be treated. They are the treatable causes of dementias. When it comes to the chronic cases like irreversible cases like Alzheimer's disease, this is one of the disease which is a neurodegenerative disorder. This starts gradually and progresses over a period of time, and the activities of daily life get impaired over a period of time. These people will have the issues with memory. They can have speech difficulty called as aphasia or dysphasias. They can have difficulty in doing some of the repeated activities that's called apraxia, which is normal activities can be forgotten. They can have agnosias. They can have executive dysfunction. That means the way they used to do some of the works and execute the works, they will be having difficulty in executing certain activities. In coming to other forms like vascular dementia, this is due to the blood vessel disorders. It may be because of the small vessel ischemic disease, or it may be a large stroke. Sometimes these things can also impair the memory areas. Usually they will have the acute onset. That means usually the stroke is acute, suddenly it comes, and there can be stepwise decline over a period of time. They will have a vascular risk factors like atherosclerosis, hypercholesterolemia, or sometimes hypertension, diabetes, or some of the risk factors for this. And they usually present with the frontal deficits. Neurological signs will be there. They can have the weakness of the limbs, or they can have the impaired vision, and this can other neurological deficits can be associated with this. And when you do the imaging, there will be some of the neuroimaging findings will be there in these cases. And coming to the other forms of dementias, like dementia with Lewy bodies, this is one of the dementias where the Lewy body, these are some of the pathological bodies which get accumulated in the brain over a period of time. They usually present with hallucinations. They also have the symptoms like Parkinsonism like symptoms. They can have tremoriness or slowness of walking or rigidity of the limbs. They usually have the fluctuations. They have the attention problem and executive dysfunction will be there. Visuospatial impairment will be there. That means they are not able to gauge the distances. They are not able to see the normal routine activities which you used to do in the home. Like they have difficulty in remembering the things like rooms. They are not able to remember whether it is a kitchen or a bathroom or a hall or a dining hall. So these are called dementia with Lewy bodies. And another variety is called frontotemporal dementia. Usually this type of dementia happens at early ages, and family history will be there in these patients. Some of the genetic disorders can be there. They have difficulty in executive dysfunction. These people will have behavioral problems like personality changes will be there. They will have disinhibition. That means they don't know what to do in what place. That means they can start urinating in a public places, or they can do something which is illegal to do in a public places without their knowledge. And they can have the problems with speech also. So that's why The differential diagnosis of dementia first requires ruling out some of the reversible causes, what I told you earlier, like depression and deficiencies, nutrition deficiencies. Later, the next step is to distinguish between the irreversible and the irreversible form of dementias like Alzheimer's disease, vascular dementia, and this dementia with Lewy bodies and frontotemporal dementia. That means initially you have to differentiate whether it is a dementia or not. Later, you have to segregate into reversible and irreversible forms, and later you have to see which category these dementias fit into. So this is some of the key steps in diagnosing the dementia subtypes are this usually starts with a mild cognitive impairment. So these people should be assessed with some of the objective measures, like objective scales are available, but they usually have activities of daily life which are preserved. And rule out the reversible cause, as I told you earlier, and differentiate by the symptoms. Some of the symptoms can differentiate between different types of dementias, and identify the common subtypes, whether it is a Alzheimer's type, vascular dementia type, or some of the Lewy bodies or frontotemporal dementias. So after you take the history and diagnose by taking the symptoms and all, so there are some of the screening tests which are available. How to screen and when to screen is very important. So usually assessment for this MCA means minimum mild cognitive impairment in symptomatic patients. It's not just normal aging. Usually normal aging also may be associated with some amount of memory impairment, but with this should not correlate to that particular age. It means if it is out of proportion to that age, then it is called as a mild cognitive impairment. We use some of the validated tools like mini mental status examination and Montreal cognitive assessment scales for suspected cases of neurocognitive disorders. Whereas in high risk groups, especially those with the age of more than 65 years, those who have a family history of dementias and some of the genetic form of dementias, we consider the genetic testing and regular screening to be done in these type of patients. So what are the assessment tools? How we are going to assess the cognitive impairment in Alzheimer's disease? So as I told you earlier, the important thing is the history. Usually the patient with Alzheimer's disease, history-wise, they are usually aged more than 65 years. Occasionally, they can be early age of onset if it is a genetic form, if it is involved like ApoE4 gene. If it is involved, usually it can have early onset, usually before 60 years also. And what are the forms of memory which are affected in this that we have to see? What are the behavioral changes which are affected also has to be taken. Then we do have to do the physical and neurological examination to rule out the reversible causes of dementias, like any depression is associated or any deficiencies of the vitamin or thyroid impairment is there that you have to see. Then after this, some of the assessment tools are available, as I told earlier, like MMSE, that is mini mental status examination, which encompasses many of the forms of questions are raised, like it includes calculation, naming, some of the executive function activities like drawing a clock, all these things are involved in this. Then similarly, we use MOCA, that is Montreal Cognitive Assessment Scale, and clock drawing test is used for seeing whether the executive function is preserved or any visuospatial impairment is there that you have to be checked by this test. Then others like advanced cognitive neuropsychological battery, various types of batteries are available, which is useful for detailed profiling if needed. And this can assess which part of the brain and which lobe is affected, whether it is the right side, left side, or whether it is different lobes like frontal lobe, parietal lobe, temporal lobe, or occipital lobe. These are sometimes the different lobes can be involved in various dementias. And then comes the lab investigations, where we usually do the blood investigation initially, like we usually do the blood count. Then comes the electrolytes to rule out any metabolic causes like any chronic hyponatremia or any other forms of electrolyte impairment. Thyroid disorders has to be ruled out by doing the thyroid profile. Vitamin B12 deficiency, we do vitamin B12 test. Some of the infections like HIV associated dementia are also available, are seen, and syphilis can be associated with dementias. Then later comes the imaging studies like MRI of the brain, CT scan of the brain. If MRI is not available, we can do the CT. And iron tests are also available, like PET scans are available nowadays to see the different chemical uptake in the brain, like amyloid and FTG and tau protein associated PET scans can be done for differentiating atypical or uncertain cases in atypical and uncertain cases. And CSF analysis can be done, where we can see whether the presence of A beta 42 tau, and plasma biomarkers, which are emerging biomarkers. Some of the emerging biomarkers are also there, which can be seen through the CSF analysis. I will tell you that advanced biomarkers which are available now recently. However, this is not easy. There is a lot of challenges in the diagnosis of Alzheimer's disease. So, what are the challenges categorized into three to four different types? Like one is the limited availability and time, limited availability of the time and resources to the clinicians. Second, limited availability of the clinicians themselves, like neurologists and psychologists. Then variability in the presentation, the way they present, there can be mixed features or some of the comorbidities can be associated with this. So that may confuse in the diagnosis of Alzheimer's disease. Sometimes misdiagnosis can come into picture because various differential diagnoses are there. If we are not able to diagnose properly, misdiagnosis can happen. And very difficult to get all the tests done for a patient because many of the tests may be having a very high cost, and the non-availability of the test is also one of the factors. So what are the hurdles? As I told you earlier, we know that aging population there is growing number of elderly patients nowadays in India. There is an increased demand for diagnosis. Overwhelming existing services are also limited. Limited clinicians for geriatricians, neurologists, and neuropsychologists are not many in India. This creates long waiting period, and there are a lot of barriers in assessing these super specialists and super specialists. And then comes the time and resources. A proper diagnostic workup is the time consuming because this requires a detailed history. Sometimes a neurocognitive assessment and battery of tests will take more than 1 hour for one patient, or it may take up to 2 to 3 hours also sometime. And a luxury in the busy clinical practice, no one wants to do this because, see, if you lose 2 to 3 hours in a day for a patient, single patient, it's a very time consuming and hectic procedure. And the lot of high cost of the tests for these PET scans, MRI scans, and a lot of biomarker studies or CSF which are available are also very expensive. And last thing is, none of these things are covered under insurance, and patients are not affordable. So this is also one of the hurdle for the patients, and also for the clinicians. It is also hurdle to, because it's very difficult to rule out some of the differential diagnosis. Many of the time we diagnose these things by just by history and physical examination. So there's a lot of complexity in the way the patient presents towards. The key challenge is the disease itself is variable, and often it is masked by other comorbid conditions which are associated with that. And the presentation can be varied from patient to patient. Some patient can have mild memory impairment but lot of behavioral changes, or some patients can have behavioral changes with mild behavioral changes with severe memory loss and language problems. So variability of the presentation is also one of the factors. And many of the times other comorbid conditions can be associated with the patient who is suffering from Alzheimer's disease, like they can have both dementia also, and also depression can also be associated with that. Vascular diseases, that means that the patient may have a lot of vascular problems, like a stroke can be there, or they can be diffuse cerebral small vessel vascular disease may be there. They can be suffering from uncontrolled diabetes also. These things can overlap or they can mimic like dementia, and this can complicate the picture in diagnosing the Alzheimer's disease. And broad differential diagnoses are there. So better first rule out all the reversible causes, try to treat the reversible cause. Then we should think of diagnosing and settling it as an Alzheimer's disease. So I told you about the limitation in the diagnostic process also. So there is a lot of misdiagnosis because of various factors. As I told you, false positive and false negatives are also common in this. Incomplete screening, in-office cognitive screens can miss early or subtle signs of dementia, especially in highly educated individuals. It is very difficult to find out the mild cognitive impairment or milder forms of dementia. And inefficient screening due to lack of standardized, efficient, and widely adopted screening protocols. This can lead to inconsistent detection rates across the primary care also. So as I was telling you about the newer biomarkers, the future, which are the future for the diagnosis. So a lot of things have been are there in the research pipeline, and now what we are seeing now is we can measure the plasma A beta 42/40 ratio. This tells about the burden of the amyloid protein which is accumulated in the brain, because the Alzheimer's disease means what? It is nothing but the accumulation of a abnormal protein in the brain cells, that is neurons. Usually two types will be there. One is called as a amyloid plaque, where it will be clumping of the proteins happens because of the amyloid. And the second form of pathological abnormality is the neurofibrillary tangles. This is due to the tau protein. The tau protein forms the fibers. It entangles and forms the filament, and this also accumulates in the nerves, neurons. So this leads to abnormal to and fro movement of the information, and also the chemical reactions which happens inside the brain will be altered. So that leads to the dementia. So we have to think of how to diagnose these things. What now I am talking about the diagnosing. Later we have to see about the therapy also when we are talking about this pathology. So now when it comes to the diagnosis, some of the blood biomarkers like plasma A beta 42/40 ratio, this reflects the amyloid burden in the brain. This also helps in early detection capability also. The second thing is plasma p tau 181/217. This correlates strongly with the tau PET imaging and predicts the disease progression. How fast the disease is progressing can be predicted with this. Then comes the neurofilament light. This is a marker for neurodegeneration that predicts the cognitive decline trajectory also. So clinical utility of these biomarkers are emerging as first-line, accessible, and cost-effective screening tools for widespread clinical use. Nowadays, in the cosmopolitan cities and metropolitan cities, we are able to assess these things, and we can use this on day-to-day basis from now. So there is a need for early and accurate diagnosis is very important, because clinical timing window is very important, and also the paradigm shift also. When it comes to the critical timing window, treatment shows greater effectiveness in asymptomatic or early stage of the patient before irreversible damage occurs. This is the critical timing window, and the paradigm shift is moving from reactive symptom management towards proactive neuroprotection and disease modification strategy is important. See, nowadays what we were doing now is we were treating the symptoms, but however we are not targeting the disease or not trying to halt the disease or reverse the disease process. So what is important is early intervention during the preclinical phase itself is the best opportunity to meaningfully impact the disease trajectory and preserve the cognitive functions. That means early diagnosis and early treatment will preserve a lot of cognitive part of the brain, especially in the patient with Alzheimer's disease, if it is detected in when it is asymptomatic or early stages of the disease. So that is what are the current challenges in the treatment of Alzheimer's disease is less disease modifying effect of the symptomatic relief drugs which are available now. Most of the time we are using cholinesterase inhibitors and memantine. This only provides symptomatic relief. The modest benefit is it improves the cognition, behavior, and daily function, but these are all temporary and variable. And however, this treatment initiation also happens very late. So adverse side effects are seen with cholinesterase inhibitors, like they can have GA symptoms. When it comes to the memantine, they can present with dizziness and confusion, and the tolerability may be limited. And many of the time patients are on multiple drugs, and that's why poor adherence is also one of the important factor in elderly when they are in the polypharmacy treatment. So broader therapeutic challenges there, that is we don't have the many clinical trials which have the positive results. Multiple trials have been done till now on targeting the amyloid tau proteins, and many neuroprotective drugs have been tried, but they have showed a limited success. And due to the heterogeneity of the disease, lack of biomarkers for early intervention therapy, and the intervention therapy starts too late to alter the progression in these cases. And the high cost of the emerging therapies is also one of the important things, because nowadays we are seeing the monoclonal antibodies, especially which have been used to target the specific pathological process in the brain. We use monoclonal antibodies like aducanumab and lecanemab, they pose an economic barrier because of the cost itself. So how we have to manage the patient with Alzheimer's disease is very important. As of now, we have only the two drugs which are available, like cholinesterase inhibitors are available, and second one is the memantine, which is an add-on or alternate drugs which is available. So cholinesterase inhibitors like donepezil, rivastigmine, and galantamine is available. This improve the cognition and global functions, but cost effectiveness in clinical practice is also good in these drugs, not too costly. This can be tried in mild, moderate, and severe forms of Alzheimer's disease. Initially, we usually start with cholinesterase inhibitors. Majority of the time, it is the donepezil which is used. Sometimes we use the rivastigmine and rivastigmine. Galantamine we don't use much, but they can be used at later stages. In moderate stages, we use cholinesterase inhibitors and we can overlap with memantine, which is an NMDA receptor antagonist. And the last severe form, we usually combine these drugs, and this provides a broader cognitive, functional, and behavioral benefits when it is used. However, we are not targeting or reversing the disease process, or we are just able to maintain the symptoms. So symptomatic management is done in these cases, and little bit of progression can be altered. In cases of mild cognitive impairment, do you have to treat? So still that is a question mark. Usually we don't recommend treating these patients. However, we keep them under observation. We usually do the test once every 1 year who are at risk of developing the dementias. This cognitive assessment can be done every yearly to see whether the disease is progressing from a mild cognitive impairment to the dementia. So there are a lot of non-pharmacological interventions also. For cognitive and physical intervention, we usually recommend exercises. This improves the blood circulation to the brain and also improves the oxygenation and improves the executive function. Cognitive stimulation happens by doing this training. Lifestyle modifications like dietary changes like Mediterranean diet is recommended, and also DASH diet is also recommended for these patients with Alzheimer's disease. Advice to prevent stop smoking and reduce the alcohol intake. Other interventions like acupuncture and psychotherapy is the other forms of interventions which has been recommended. So as I told you, the dietary modifications is Mediterranean diet or DASH diet is done. Acupuncture is done for those patients with mild to moderate Alzheimer's disease, usually 3 times a week for about 12 weeks, which enhances the cognitive scores. Cessation of smoking is better, and quitting the alcohol is also important. And some of the behavioral therapies also can be given along with the pharmacological therapy for severe forms of Alzheimer's disease. So there is a drug. Another thing is the L-serine, an endogenous amino acid. This is a potential neuroprotective agent for neurological disorders and some of the injury to the brain. This has been tried in various forms of other CNS disorders, especially in ischemia, hypoxia, trauma, and also in case of toxins-induced damage to the brain. This limits the neuronal damage, cell death, and also it helps in preventing the brain tissue degeneration. This supports learning. Also, it enhances the memory and cognitive function by preserving the neuronal health. So what is the role of these things in reducing the inflammation? L-serine, especially the L-serine, this modulates the immune response in the brain and also reduces the pro-inflammatory factors. Then also it protects the microglia activity. Microglia is also one of the cells in the brain which helps in supporting the repair and recovery of the nerve cells. So this helps in protecting the microglia. And it also limits the secondary brain damage and improves the neurological outcomes. That means L-serine usually crosses the blood-brain barrier and helps in doing all these things by decreasing the inflammation, and also it helps in protecting the nerve cells by repairing through the microglia activity, and also it helps in improving the neurological outcomes by preventing the secondary brain damage. So, as I told you, it also enhances the blood flow and promotes neuron stem cell survival and regeneration, which helps in repair and facilitates recovery of the motor and cognitive functions after the injury to the brain. So, does L-serine can be used for as a therapeutic option? When it compared to the D-serine doesn't crosses to the blood-brain barrier much. When it comes to the L-serine, it crosses well, and it is better tolerated and safer profile is there. This has been tried in HSAN1, that is hereditary sensory neuropathy type 1, at a dose of 400 mg per kg per day, divided for 2 to 3 doses for 52 weeks. Similarly, this has been tried in another neurodegenerative condition called motor neuron disease, where ALS, that is amyotrophic lateral sclerosis. Here, oral L-serine supplementation is safe, but no impact on the disease progression in these cases. That is a phase 1 trial. In phase 2 trial, it is planned to assess the efficacy further. So, also L-serine in green 2B related disorders, especially glutamic acid N2B containing NMDA receptor function. This helps in decreasing the glutamate affinity. That means this mutation, especially many of the disorders who have this green 2B mutation with encephalopathy in a 5-year-old, this supplementation improved the NMDA receptor activity. And there was a marked improvement in motor functions, cognitive functions, and also the communicative functions after 11 and 17 months. And other green 2B related neurodevelopmental disorders in pediatric patients, they have tried dosing of about 500 mg per kg per day into 4 divided doses, and measured the outcomes, which showed the increase in psychomotor development, and it increased the alertness and communication skills. Especially, this has been reported, have been taken from the caregivers. And how we are going to monitor the long-term management of the Alzheimer's disease is also very important. So here, long-term management involves regular follow-up with the doctor, especially the neurologist and also the neuropsychologist, to measure the cognitive status of the patients and whether it is progressing from a mild cognitive impairment to the dementias or the dementia different stages, whether it is progressing from stage 1, 2, and 3 like that, mild, moderate, and severity. Then periodic follow-up has to be done at least once a year or once in 1 or 2 years for those who have this kind of memory impairment. The patient care support groups should be there, and caregivers should be educated about the Alzheimer's disease and the way it has to be managed, and when the medicines has to be given, and what type of treatment has to be given to the patient has to be educated to the caregivers, because that also adds a lot of financial burden also, and also psychological effects will be there on the patient and also on the caregivers. So what are the recent advances in Alzheimer's disease? Sharpening the focus, selective inhibition is what is important. That means nowadays, now what we are doing is we are not targeting the process itself. That means the pathological process is not targeted, pinpoint targeting is not done. The challenge is traditional pan inhibitors like multiple enzymes, often leading to cytotoxicity and adverse effects without disease specific benefit. The precision approach is what is important, like GSK3B inhibitors, that this reduces the abnormal tau phosphorylation, a driver of neurofibrillary tangle. And then other things like HGSC6 inhibitors, this blocks the tau aggregation and support the memory functions and add antioxidant property also. This tau protein and beta amyloid protein, as I told you earlier, they are the one which are causing damage to the brain. So if we are targeting specifically into the accumulation of these tau proteins, or formation of the tau protein itself can be prevented by some of the research things which are happening there. The last one is the JNK3 inhibitors. This prevent the neuronal damage and tau tangle formation, showing behavioral improvement in Alzheimer's disease. This investigation, these research are happening in the mouse models in Alzheimer's disease. So, multi-target directed ligands are also very important. What are these multi-target directed ligands? Single target drugs often fail because one pathological process, if all the other pathological process may be happening, like different proteins are involved in this. So multi-targeted directed ligands therapy is is required in the future research. The benefits of this is usually they will have a synergistic effects, lower the pill burden to the patient, and there won't be much drug-drug interactions, and compliance with the patient is also better. So examples like acetylcholinesterase plus butyrylcholinesterase inhibitors. This enhances the acetylcholine and slow A beta plaque formation. That means the beta amyloid protein accumulation also get inhibited or it slows down. Next comes the acetylcholinesterase and MAOB inhibitor. This ladostigil. This is a phase 2 trial which is happening now. This may delay the progression from mild cognitive impairment to the Alzheimer's disease progression. So initial stages of MCI, if it is detected, this can prevent going into the Alzheimer's disease in future if there is a risk of developing Alzheimer's disease in these patients. Then comes the acetylcholinesterase and phosphodiesterase 4D inhibitor. This is stronger neuroprotective agents and also has got an anti-inflammatory effect versus the drug combos. So these things can be directed together. That's called as a multi-targeted approach and can have a lot of beneficial effects by using these drugs. So how to prevent and early intervention is also very important for the patient with Alzheimer's disease. This is the future of Alzheimer's care lies not in treating the symptom, but in preventing their emerging symptoms through a strategic approach. Evidence-based approach and interventions are required during the critical preclinical window itself. That means before the formation of the Alzheimer's disease from MCI or at the early stage of Alzheimer's disease, if you are able to treat the patient, then it is a very good option. And we can prevent the progression of the disease. Thank you.
Thank you so much for that valuable talk, sir. We have a few audience questions. So,
Yeah.
In the interest of time, let's conclude, sir. So we first have Dr. Shiva, who asks a practical question. In patients with visual impairment or hearing impairment, these patients tend to have a early risk of dementia because of a poor cerebral processing of information. So, what is the role of rehabilitation very early on at the level of the ENT specialist or the ophthalmologist? Your take, sir.
See, many of the times in Alzheimer's disease, they will have a visuospatial impairment. That means the process is not in the eyes, it is the processes which happens in the brain. That means the information which goes from the brain to the eyes are getting impaired. They are not able to gauge the distance. Whether if I ask them to take the cup of coffee, they're not able to gauge the distance of the cup properly. Or there can be visual apraxia. That means, see, if we know that the kitchen is there and room is there and the bathroom is there, but they don't know where to go because they're confused. They're not able to differentiate between these things. That is called spatial disorientation. So here, definitely, rehabilitation can improve this function by giving certain tasks to them. So, lot of nowadays, lot of computerized activities are available, which can stimulate these areas in the brain which are weaker, and lot
Sure,
of
sir.
cognitive activities can be given to improve these functions.
Sure, sir. So the next question we have is from Dr. Mukul. Dr. Mukul is a physician, and he says for patients who come with symptoms of dementia, before referring to his neurologist, he often takes a 3-Tesla MRI to rule out any other pathologies. He also rules out vascular dementia very commonly, where he has patients with hypertension and sees follicular infarcts. Sir, is his approach right from a physician's perspective, or there's anything else that a physician can do before sending the patient to a neurologist?
See, most important thing is the history. As I told you earlier, the history is very important, whether when you're diagnosing it as dementia. Many of the time, what we do is just take the history as memory. Any memory impairment, we diagnose them as Alzheimer's disease and we put them on donepezil or memantine. See, that is not correct. Always ask the history properly. Whether the disease is acute onset or it is chronic one, it is present from many days. And whether it is a gradually progressive disorder or whether it is acute and static, immediately it happens, severity is more. Because, and then other things are also like any associated symptoms you should ask. As I told you earlier, if it is a vascular dementia, usually they can have some of the neurological deficits also, like they can have the weakness of one side of the body, or they can have the visual hemianopia, they can have the other vascular stroke-like features can be there with them, associated with them. So then in another form, you have to ask like behavioral issues also you should take it into consideration, whether there are some of the frontal lobe dysfunctions which are they seen in these patients, means only the frontal lobe getting affected or temporal lobe get affected. in these cases, especially in the FTD, frontotemporal dementias, they usually have a lot of behavioral problems. Memory issues will be there, but it will be out of proportion to the behavioral problems. A lot of disinhibition will be there, aggressive behavior will be there in these patients. And these type of patients, FTDs, can progress very fast compared to the Alzheimer's disease. And then another thing I told you about the dementia with Lewy bodies, they also present with hallucinations. So this is how you have to differentiate with the history itself. Majority, 70% of the diagnosis is done by history. And then comes the investigation, as I told you, to rule out the blood investigations are first we have to do it, because you have to rule out the reversible causes. What is important here is not just diagnosing it as dementia or reversible dementia is very important, because there is a treatment option which is available and you can reverse it, like deficiency, especially common things we should do, like vitamin B12 deficiency, thyroid, you have to correct properly first. Any electrolyte imbalance is there, you have to see and correct those things. So these things has to be taken care first, then comes the imaging later. Because once everything is normal, then you have to do the imaging to see that imaging also is very important. Sometimes what happens, there can be stroke in the non-eloquent areas. That means there may not be any weakness of the any part of the body, but they can have the blood clot, or sometime a wall stroke can be there in the temporal area, temporal lobe, which is considered especially in the hippocampal areas. If it is there, they can have the memory problems. Similarly, sometime elderly patient, if they have a fall 2 months or 3 months or 4 months back, it's with mild injury to the head, but they would have not noticed any problem that stage. But later stages, they can have the memory impairment. And sometimes, if you do the simple CT scan itself, we can see the subdural hematoma. If you do the subdural hematoma, it is there. If there is a mass effect, if you evacuate it, then the memory can improve sometimes. So this is how we have to do, and definitely we have to do the imaging. Like MRI can be done, whether it is 1.5 Tesla or 3 Tesla. We can do the MRI scan just to rule out the other causes. Sometimes the tumors, slow growing tumors, especially in the temporal lobes, can also present with these kind of symptoms. They may not be having any deficits except the memory impairment, memory problem, or behavioral problems. So this is how you have to do. MRI can be done at also, but this has to be done in a stepwise manner. As I told you, the approach should be stepwise, because we should not miss something in between. So if we do directly CT, MRI scan, and if you come to the diagnosis that it is a dementia and name it as a Alzheimer's disease, then if you're not correcting the reversible cause, then you are not giving a proper treatment.
Absolutely, sir. Spot on. And in your slides, you have very wonderfully spoken about history, clinical examination, ruling out encephalopathies versus dementia, speaking about differential diagnosis for dementia, be it frontotemporal, Lewy body, or Alzheimer's. So wonderful, sir, and a great harp on the same once again. We also have a question from Dr. Dheeraj, who acknowledges you showing the CSF biomarkers, the A beta 42 emerging biomarkers. But he also says that, sir, they are not yet completely validated and they're not largely available. So in the current scenario, I think his question is answered because you have already answered the stepwise this. So he's just asked how to proceed stepwise clinically. And you also wonderfully answered that point in the previous question. So we also have Dr. Pranav asking, combining anticholinesterase inhibitors like donepezil with NMDA receptor antagonists. You've already touched it in your slides for mild, moderate, and severe dementia. But nevertheless, Dr. Pranav would want to hear from you once again. When to initiate and how to initiate?
Yeah, usually in the initial stages and the mild cases, we usually give donepezil as a first line, that is the acetylcholine esterase inhibitors. Then, if it is a moderate cases and severe cases, we can initially start with acetylcholine esterase in moderate cases, then add the NMDA receptor antagonist. And in the severe forms, we usually give both the drugs together.
Thank you, sir. Dr. Arul asks, any role of nutraceuticals or micronutrients in Alzheimer's disease?
Yeah, as I told you earlier, see, they are all the supplements. You see, each drug has got a individual effects. But what happens when we are administering all these drugs to the patient? We are administering the polypill, polydrug, polypharmacy. See, what happens? You may take the vitamins, but you will not take this drug which is required. That is the main drug. They may not take. That means always try to avoid too many drugs for these patients. You can add the multivitamin like vitamin B12 supplements can be given, and antioxidants can be given. That's it. Other drugs we usually not recommend much.
So the last question from Dr. Manish for the day: artificial intelligence in the management of dementia. Do you see a future for that? Artificial
Yeah.
intelligence helping patients with dementia.
Yes, definitely. Because artificial intelligence can play a very important role, especially as you are speaking about these pathological things like tau protein detection, amyloid, beta amyloid accumulation, measuring the burden of these proteins in the brain, and whether it is in the initial stage, whether we can prevent the progression. Initial stages can be picked up with these drugs, these artificial intelligence techniques. Second thing is about the imaging studies. Lot of imaging available, like PET scans with various protein detections. This itself can pick up the artificial intelligence can pick up the pathological areas in the brain, and it can also measure the burden, and in future it can measure the burden progression also. See in what path it is progressing. These things can be. I think it is going to revolutionize in future. But however, whatever happens with artificial intelligence without the clinical knowledge, it is waste. That means all the clinical stepwise approach what I told you, that has to be taken care first. Artificial intelligence, whatever form it can improve in speeding up the process. That's it. That means it can help in speeding the process of detection, and also it can help in giving a trajectory pathway also.
Thank you so much for the same, sir. We are at the end of our audience question and answers. We thank you very much for that very endearing session, a very practical take on how to approach a patient with dementia and Alzheimer's disease. We are very sure that the audience who has attended this webinar would ultimately get empowered to uh, take some practice perspectives and clinical pearls into their practice. Based on what we have got right now, we have 925 logins, is what I see. So that's great on a Sunday evening, sir, as you rightfully know. We thank you too, dear audience, for taking your valuable time to attend this webinar and ultimately have takeaways to ultimately improvise your practice and patient care outcomes. Last but not the least, we also thank our wonderful technology partners, DocMode, for aiding in the very smooth streaming of this webinar. So thank you, one and all. Have a great day. Good night.
Thank you.